Hello, good morning, everyone. This is Dr. Farooq from Skill Lab, and again we have Dr. Said once again with us. Hello, Dr. Said.
Good morning, Farouk.
So it's pleasure to have you after a long time. I think we've been busy for the last few months, and then uh, we didn't have any time. But today we're gonna do a different kind of podcast today. Rather than going through the theoretical bit, we're gonna discuss some interesting cases. For
Yeah,
example, chest pain is one of the most common case that comes to emergency department. Many times we think it's non-cardiac, we discharge the patient, but we don't know what happened in the other end. So I think Dr. Said is going to tell us, we're going to share with us an interesting case, which actually came as a non-cardiac or non-emergency type of chest pain in emergency department, discharged from there. Dr. Said, can you start the case, how it actually initiated, it came in emergency department, and what happened then after that?
yeah. Thank you, Farouk. Thanks for having me once again. I started really liking your podcast.
Thank you. Thanks.
So, before I start the case, being an emergency physician in NHS, how often you think about an endocrine diagnosis when you deal a chest pain in
It's a
ED?
very good question. Almost never. I'm telling you, it's not in the differential. Nobody thinks about endocrine cause of chest pain. It's I'm happy honest. Okay. It is very rare. It's not at that part of the differential. Yes, that's I think that's probably one of the trigger of this case that yes.
Yeah.
And also, if you know the NHS setup, it's a very short time frame. We don't have the luxury for the investigation comes, and a lot of like follow up and other things. Definitely, we are not in the right place.
Of course, yeah. The case I'm going to discuss, of course, you're right. Chest pain and direct endocrine cause is rather rare. The gentleman I'm going to discuss, he presented with chest pain, and I would say not direct, but an indirect um, effect of his endocrine problem, which was later diagnosed
Right.
in a with a rather significant endocrine problem. So, if I start, so this is a gentleman who was completely fit and well. He never been to hospital. That was his first hospital encounter, any encounter as an adult. So I think he works in an industry. He lives with his family, completely family
How
man.
old how old is the patient?
He's in his fifth decade, mid
50s.
40s.
50s. Okay, yeah.
Yeah. So he's in his mid 40s.
Mid 40s.
Yeah. So, just a normal man.
Yeah.
Living his life, working, fit and well. No
No
health
history.
scare, not at
No
all.
risk factors. No cardiac risk factors.
No cardiac risk factor. He never smoked in his life. He eats healthy. He is very active, lives an active life,
Yeah.
works in a desk plus or manual
Yeah.
job, but also goes for golf,
Mm.
walks his dog every day. So a fairly active man. And it all started around late last year, October 2025.
Mm.
I think he had a bit of chest pain, very peripheral chest pain.
Yeah.
He talked to his wife. They both were okay. They both thought it's a minor chest pain, as we all encounter. They took some painkiller at home, gave it a couple of days.
Mm.
Uh, One morning, woke up with a bit of worsening, so rushed to A&E. When they came in A&E, picked up by one of the A&E registrars, and they did everything, I mean, normally as you would do. After their assessment, they found a new LBBB, so new left bundle branch block.
And just for me to understand, how long was the chest pain, the duration before he showed up in A&E?
So there was a good couple of days,
Oh, good
but
couple
the
of days. Okay.
worsening was, say, few hours.
Okay.
Few hours of worsening, and they just took few hours to decide whether
And
or not to go to A&E.
and what type of chest pain and where?
So it's a very localized, very focal left-sided chest pain. Very, he would, if you ask him to point out, he would point out on a few centimeter area on his left chest. Uh,
Right.
I would say he showed it around left seventh, between sixth and seventh intercostal space. Very
Right.
painful chest pain.
Wow. So
So as it
you're saying a young 40-year-old with no cardiac history, coupled with chest pain, coming with a worse kind of pinpoint hit on the
pinpoint.
chest, and as a new LBBB. Okay.
Yeah. So the ECG found a new LBBB and nothing else. Everything else was normal. What he would do, I mean, just out of nowhere, a very non-cardiac peripheral chest pain, no risk factor, no other features. Troponin was done on two
Yes.
samples.
Yes.
First sample was 5, second sample was 6.
Right. Again, that patient goes home from ED. I can
Yeah,
see it.
yeah,
Or GP follow up. Okay. And
yeah,
advice.
true.
That's
So
yeah.
yeah, if I show you, I mean, if I show you my screen, then you'd see. Do you see my screen now?
Yes.
Okay.
Yes.
So you see that October 2024 initial presentation, acute
Right.
admission with chest pain, his hemoglobin was fine, and LBBB was identified.
Right.
And you were right, absolutely right. He was discharged as non-cardiac chest pain. However, the ED team actually involved acute medical team who involved cardiologist.
Wow. That's interesting.
Yeah, so I can see there's a lot of insight from front door. So
Yeah.
cardiologists saw and they planned for an echo.
Oh, wow.
So he had an echo, and the echo was fine, nothing wrong as expected.
Hmm.
And he also was planned for an outpatient cardiac MRI.
Right.
I
Wow.
think they gave maximum attention to the detail. They tried to give maximum attention to the detail because he's a fairly young man presenting with a new LBBB. So they just wanted to see there is no stone that remain unturned.
Yes. Yes.
Anyway, he went home with a bit of painkiller, pain resolved, and he moved on with his life
Hmm.
for only for a few days. But then he had to present to his GP because a persistent cough that was going side by side since
Right.
July, say I would say few weeks.
Right.
So GP then put things together.
Hmm.
The persistent cough and pleuritic chest pain.
Right.
And GP also digged out night sweats. So GP got worried about any inflammatory process, infectious disease, or cancer.
Right.
So he did some radiology.
Hmm.
He did a chest X-ray that showed some hilar prominence, and he also requested a CT chest in a 2-week pathway,
Yeah.
and at the same time made a respiratory referral. So
That's interesting. Side,
Yeah, that's
if
very
I
interesting.
if I am just thinking around, if
Yeah,
someone coming with periodic type of chest pain, cough for a few weeks,
yeah,
localized in the left
yeah.
chest, I'm just thinking maybe we could have considered chest X-ray from the ED side. However,
Interesting. Yeah. So he he didn't have a chest X-ray.
right,
Well,
right,
yeah, yeah, yeah. So that's a pitfall, right? Shobhit for
yeah,
way you picked it
yeah.
right actually. So um,
But
number two, if anyone would come with chest pain, what would you do, like in terms of investigations? It's
again,
probably
it's
number two and number three.
yeah, it's also, we do the risk assessment, we do the heart score. Okay, normally
Yeah.
risk assessment heart score will give you rough idea what to do. Again, there are more non-cardiac chest pain than cardiac, I agree.
Yeah.
Okay, depends on the presenting symptoms. If somebody is coughing and we're thinking it's respiratory or pleuritic, depends. And not always everyone gets the chest x-ray, but someone is more symptomatic, they do,
Mm.
to be honest. Well, I again, since I'm not going to comment why, but again, I see that the patient probably wasn't that coughing that bad enough to get the chest X-ray
Mm. True.
immediately.
True. And also lifelong non-smoker.
Yeah, yeah, yeah.
And of course, no history suggesting a chronic process
Right.
um, or a cancer in ED. And probably all got distracted and moved toward cardiology because of finding of a new LBBB.
True, true.
So he had an echo, but not a chest X.
That's interesting.
Yeah.
But that's actually makes us think wider, Let at the end,
Yeah.
obviously, GP,
GP
can
did it.
talk.
Yeah.
Yeah,
I mean, GP couldn't do an echo.
yeah, yeah.
This is the first investigation he could do, so he went with obvious.
He would have done echo and X-rays. But again, I think the only thing on the pathway of the chest pain, GP was thinking, oh, everything else from cardiology side is done.
Yeah,
This is sporadic. How about a chest X-ray?
yeah.
Right.
And also by that time, patient came up with more symptoms like night sweats.
Yeah.
And so if you complain of chronic cough and night sweats to any NHS GP,
Hmm.
they will
They
book
would
a
do.
two-way pathway CT chest.
Yeah, that's true. 2 week.
Anyway,
Yeah.
so do you see this Microsoft sheet on the screen?
Yes, yes.
Okay. So CT chest was done in December 2025, precisely.
Right.
And that showed that changed shifted whole momentum
Yep.
of the diagnostic process. Everyone got alert. They were all on their toes.
Can you increase the size of the document?
Yeah, yeah, of course. I mean, the merit of the whole case just went through the roof after the CT. It showed an infiltrating left hilar mass and a mediastinal lymphadenopathy and anterior mediastinal soft tissue mass. And radiologists thought it's either lung cancer or a lymphoma.
Right. Said, can you widen the page for us on the screen?
Oh,
Yeah,
it's
yeah.
better?
A bit more, bigger.
Okay.
Yeah, that's fine. Absolutely. That's fine.
Okay.
Yeah, I can see now. Yeah, wow. So CT chest
Hmm.
on December 12th, left hilar mass,
Yeah.
extensive mediastinal lymphadenopathy. Wow. Measles soft tissue mass and suspicious malignancy. Wow.
Yeah. So radiologists thought it's either a lung cancer
Mm,
or a lymphoma.
right.
He made a referral to respiratory who picked up
Yeah. And
urgently.
that's not unreasonable. That's how
Mhm.
you normally pick up with
Yeah,
this presentation.
yeah. So respiratory saw him very urgently, and within a couple of weeks, they actually did an FDG PET CT.
Right.
FDG PET CT showed an FDGA with bilateral mediastinal hilar nodes, left hilar mass, and retrosternal thyroid enlargement. That's where endocrine got involved.
Ah,
I
so
had to go a long way.
I see, I see.
Hmm.
Retrosternal thyroid enlargement. Wow. So, I
Yeah.
mean, for the general audience, what
Hmm.
does FDG PET CT means and how it's different than regular CT? Just if you can give us.
It's a functional scan.
Yeah.
It's a functional scan with FDG, and this scan is able to pick up biological activities, functional activities in those nodes. To see those hilar masses are active,
Hmm.
it's really important to do a functional scan.
Right.
And it also functional scan was also able to pick up all the similar tissues that were taking up FDGs. So it picked up thyroid mass as well, thyroid enlargement.
But the differential still malignancy, lung
It's still
malignancy.
cancer, lymphoma. Somebody said it could be sarcoidosis, but there wasn't much to support sarcoidosis. So respiratory then talk to oncology and they plan for chemotherapy.
How about a biopsy? They don't think of biopsies?
Yes, so they did an EBAS.
Hmm.
Respiratory did an EBAS, and the EBAS showed non-small cell carcinoma.
Non-small cell carcinoma. Oh,
Yes,
wow, wow.
non-small cell lung cancer, characteristic of non-small cell lung cancer. But they also sent EBAS sample for NGS, next generation sequencing, where they do genetic testing.
And the
So, and
EBUS stands for
EBUS, endoscopic bronchial ultrasound guided washing.
washing. Okay.
Okay.
Wow.
So they did that bronchoscopy and they picked up sample from there. And that sample primarily showed on biopsy non-small cell lung cancer. So they were planning for cancer chemotherapy
Hmm.
uh, in teaming with oncology.
Right. So
They
it's
will,
now it's between respiratory and oncology. They are planning
oncology.
for chemo.
Yes, true. But they also sent for NGS the EBUS sample. NGS is next generation sequencing,
Right.
where they actually check series of genetic mutations,
Right.
and they try to see if there is any driving mutation
Right.
involved in the disease process.
Wow. Hmm.
So that took a bit of time. Meanwhile, they planned chemotherapy and immunotherapy.
Right.
And because of that thyroid enlargement in FDG PAD, they also planned a thyroid ultrasound, which
Right.
U3 and U4 nodules.
Hmm.
Now, thyroid malignancy, of course, you could think as a metastatic cancer probably coming from lung as it coming from mediastinum. So everyone's thinking.
What is U3 and U4?
So if you see a thyroid nodule,
Hmm.
uh, to understand their character in terms of malignant potential, there is a system where you can categorize ultrasonographically and categorize the risk of a particular nodule being thyroid cancer.
Mm-hmm.
That's called a U classification.
Right.
It runs from U1, 2, 3, 4. So it can be U2, 3, U2, U3, U3, U4. So, and based on sonographic criteria, the categories are different.
Hmm.
As you go up with E1, 2, 3, 4, you go to a more to a definitive thyroid cancer. So U3 and U4 are U3 is
Or
suspicious of cancer, and U4 is more of
more
likely
definitive?
of thyroid cancer.
Right.
So it's a risk stratification for thyroid nodule based on ultrasound findings. So that's what EU classification is.
Hmm.
So having U3 and U4 means you definitely have to look into histology, either
I have
with
one.
an
Yeah.
FNA or with a hemithyrectomy. For
Oh.
U3, you could do an FNA and
Hmm.
see if there is any malignant cells. Um, yes, sorry, you were going to say something to
Yeah. From like trying to understand how the endocrine get involved. So the initial there was a thyroid
Mhm.
mass on the
Yeah,
CT,
on
right?
the FDG, yeah,
And FDG, and then still based on the EBUS, the endoscopy, I mean, the ultrasound guided bronchial wash. Based on the EBUS, they found non-small cell lung cancer.
true.
Okay, so and then is it common from the lung cancer point of view to have metastasis to the thyroid?
Um, Not very common, I would say. I mean, a respiratory physician would be best person to answer
Yeah,
this question, but I don't think it's common.
it's not common. So that's why they focused on thyroid ultrasound.
Ultrasound, yeah.
Okay. And then you said U3 and U4 that might need some
So,
FNA.
tissue evidence, yeah.
Yeah, yeah,
You need tissue if you are
yeah.
classifying at least EU3 to any of the thyroid.
Mm,
So that was the plan, probably next thing to do. Ideally, the person who did an ultrasound and saw U3 nodule at least, they should have done an FNA then and there.
exactly. Hmm.
So they didn't do it. One of the reasons I would imagine the ultrasound was done by a sonographer and not by a doctor,
Right.
pathologist.
Hmm.
Um, so meanwhile, by the time at least an U3 nodule was picked up
Hmm.
with microcalcification, the NGS result came back,
Right.
and that showed this RETM918T mutation.
Can you explain these wordings, please,
So,
for the audience?
read proton cogen. This is a mutant gene, nothing
Hmm.
mutant gene. So, there were NGS look for different genes, different driver
Yeah.
genetic mutation in the process, and in doing so, they have found a proton cogen. Name is read proton cogen, and this proton cogen is actually associated with medullary thyroid carcinoma.
Hmm.
And this is also associated with MEN2 genetic syndrome, which is an endocrine, genetic endocrine syndrome.
Right. So
So
men
now,
to so medullary thyroid carcinoma is part of men to syndrome, isn't it?
yes. So this is now completely different because there's a read proton cogen mutation. There's
Hmm.
thyroid mass, which looks with its solidity on ultrasound and microcalcification.
Hmm.
It now looks like a thyroid cancer, which is actually a medullary carcinoma of thyroid,
Hmm. And
proved
also
by
they have
genetic, yeah,
severe ectopic ACTH syndrome.
yes, proved by genetic mutation.
Hmm.
We'll go to that a bit later because that surfaced later. Now the whole diagnosis has changed. Now this is not a lung cancer anymore. This is
Right.
rather medullary carcinoma of thyroid,
I have
metastasizing into mediastinum.
yeah, I have a question. So we just said EBUS confirmed non-small cell lung cancer.
Yes. The
What about
finding looked like finding showed actually what did it show? I mean, non-small cell lung cancer. When it showed evidence of non-small cell lung cancer, it actually showed cytogenetic abnormalities.
right?
They're malignant cytologies, isn't it?
Hmm.
So malignant cytology. on EBAS sample. And based on radiology and FDG finding of active hyaline nodes, mediastinal lymph nodes, they actually related it more toward a lung cancer. But now that a definite genetic mutation is
Right.
revealed on the same sample
Hmm.
and a thyroid nodule, this is now a medullary, most likely a medullary carcinoma of thyroid.
So EBUS was roughly an assumption, isn't it? So
Well, I mean, it showed
atypical cells.
malignant cytology and characteristics of cells that would simulate with lung cells, lung cancers.
Right.
That was reported as, yeah. I mean, that was more of cellular, wasn't it? They didn't take any tissue, so
No.
they didn't have a lung tissue. Of course, they had a bronchial washing.
Right. And then is that something can be common in medullary thyroid cancer or men too? Is it some these findings query atypical cells or malignant cells?
Yeah,
Is
yeah. I mean, medullary carcinoma of thyroid would definitely show malignant cytology if you take it. If you take a FNA sample or things from a distant site.
mm,
Um, I guess there are also other immunophenotyping marker they did on that sample
yeah.
that came as more in favor of medullary carcinoma of thyroid than a lung cancer. So is the immunophenotyping and the cellular marker they did later that supported medullary carcinoma of thyroid more? But the most important marker is, of course, definite finding of a mutant gene, which
Yeah.
is RET proton gene.
Wow.
So that bit is quite high tech, isn't it? We're
It
quite
is, it
cutting
is, no,
edge. Yeah.
definitely, definitely. It is very high tech.
Yeah,
And but
from
for me and I think for the audience, it's a lot to think about. Uh,
yeah.
right. And
It's a very complex diagnostic procedure though.
right.
In the shifting from cardiac to pulmonary, then shifting to thyroid, and um, starting with an ECG, then going through a radiological finding from a CT, and then from a functional scan,
Yeah.
and then
And
going to bronchoscopic sampling, and then NGS. So a lot of things and a lot of technologies involved, a lot of persons, a lot of team involved.
um one question. So what can you tell us what is MEN2? What are the organs involved in MEN2 syndrome?
Ah, interesting. So MAN2, MEN, multiple endocrine neoplasia.
Hmm.
Two is multiple endocrine neoplasia type 2. Two has got different variety as well. We are mainly talking about type 2A here. So that would involve one is medullary carcinoma of thyroid,
Mm-hmm.
and the other is pheochromocytoma,
Right.
and also primary hyperparathyroidism.
Right.
So clearly, this
And
patient has
and
got medullary carcinoma.
you have to rule out FIO and the other thing, or rule in or rule out. So
Rule out. Yeah, you have to look for. Yeah, rule in and rule out.
hmm,
So we have got medullary carcinoma of thyroid.
right.
And of course, we have to do other investigation to see if they have anything, any pheochromocytoma or any other contributor.
Hmm.
Now the question is, how is he? How is the patient?
Mm-hmm.
He was devastated
Oh goodness.
because he
It's
was told he has got lung cancer, and he was told that he's going to have chemotherapy and immunotherapy. And now he's being told, oh, you don't have lung cancer. You have a thyroid cancer, which
yeah.
is actually a very bad type and can be associated with other cancer and you have got genetic problem that can be transmitted through to your offspring.
Wow. Can I
Catastrophic.
yeah. Can I mean to me it feels like, one of the Doctor House. I don't know if you've watched this series.
Hmm.
In Doctor House, they like there one like similar cases happens in that TV series. Like
Mhm.
the patient is told that you have some confirmed diagnosis, like he said, lung cancer, small cell lung cancer, and he's mentally ready for chemo and radiotherapy.
Yeah,
Now, a couple of days later or a week later, he said, "Oh no, that was not right, and this is what you got." So patient is in psychologically imagine what's going through his head as a lay person, right?
yeah.
It's a like a lot to take in. So now we are telling him, like Dr. House, that I'm saying, referring to, that
Mhm.
now we have a genetic mutation for thyroid cancer, which can be transferred to your sibling, your next generation.
And
Uh,
and we need to investigate to see if you have more cancer or not.
ah,
That's bad, isn't it?
that is right. And is it what was it? Who break the bad news to him? Was it you or another?
Ah, no,
No.
because it was the respiratory physician who were on the spot, wasn't
Yeah,
they? And the oncologist, because
right.
they put him for a chemo
They
and they
had to.
broke the previous diagnosis.
Yeah, right. So they had to break the bad news and also uh,
Yes, while they were doing all these things,
yeah,
then he had another hospital admission by early January.
all right,
The reason for hospital admission was somebody did a full, bucket list of routine blood tests and
right.
found that cortisol is more than 600.
Uh-huh.
And the patient was also, I think, complaining of a bit of headache.
Mm-hmm.
So he came in and cortisol was more than 600. He had persistent hypokalemia
Right.
and peripheral edema. And the LBBB is now not LBBB anymore. He has new atrial fibrillation.
Wow. Hmm. That's interesting.
Yeah. So
Goodness.
that's what he had. And
Did
no,
they also do the parathyroid hormone levels and
oh yeah,
uh,
they checked calcium, which was fine.
calcium is fine, and for the
Yeah.
FEO, did they not do anything?
No, they were in the process of checking plasma metanephrines,
Hmm.
but something happened before then.
Oh,
I think they did an MRI brain because of complaint of headache, and
right.
that showed a cerebellar metastasis
MRI. Okay.
in brain. I mean, cerebellar metastasis with with some vasogenic edema around it.
Hold on. That's really interesting. So
Yeah.
was
I
it
think
what
there was
you
a bit of complaint of
headache?
headache, and also he was complaining slightly, only slightly unsteady gait.
Hmm. Wow. Was that a new symptom? So initially he
There
didn't
was
have
new.
those symptoms.
There was new.
So
Yeah.
he over the time he had developed this abnormal gaits and headache.
Yeah.
Goodness. Oh wow.
So
And then there is a um,
so
cerebral. Yeah.
now what you have?
Mm-hmm.
Now you have a genetic mutation, medullary carcinoma of thyroid,
Yeah.
mediastinal metastasis,
Right.
and hilar nodes and cerebral possible cerebral mets with vasogenic edema.
Wow.
So he was treated with dexamethasone,
Yeah. Yeah.
hypokalemia was treated,
Right.
all that. They couldn't, and for atrial fibrillation, he was started on anticoagulant.
Anticoagulant. Hmm.
Yes. And he went through other biochemical testing. If you see,
Yeah.
his cortisol was persistently more than 1400 later.
Wow.
It went up to 1600. ACTH was 124.
Hmm.
Calcitonin was 4000.
Right.
And he retained so much fluid. He has got bilateral effusion,
Right.
ascites, all sorts of things.
Can you tell us what's the normal level for ACTH and cortisol normally?
Well, up to 50. I
Up
mean,
to 50.
but in most subject, it would be in 20s or
Yeah,
30s. This is awfully high SATH.
right. So this is like a primary hypercortisol,
Yes.
isn't it?
Well, this is hypercortisol,
Mm.
not primary, because there is a driver, high SATH.
High ACTH,
So
yeah.
it is SATH dependent hypercortisolemia.
Acid is dependent, I see, yeah.
Yeah. But if you have a look, but the question is, having all this high cortisol is casting very significant toll on him. That's what I'm trying to
Mm,
um, focus on. You remember his cardiac status. He had a new LVBB with no
right,
structural cardiac abnormality.
exactly.
Now he has new AF.
And probably heart failure with edema, isn't it?
Echo didn't show heart failure, but he edema probably explained by retention of fluid.
Fluid, okay.
Because with this high cortisol, you will be retaining a lot of salt,
I
a
see.
lot of sodium, which would retain a lot of fluid.
Okay.
That probably explains his recurrent hypokalemia, because the
Mm.
more you retain sodium, the more you lose potassium.
Right, right. Mm-hmm.
So now this recurrent hypokalemia, AF, everything putting him at a risk of having a catastrophic arrhythmia again.
Mm.
His metabolic health is at the brink of
Collapse.
collapse,
Yeah,
because he's retaining fluid, one thing. The other thing is his glucose metabolism
right.
is is going everywhere. He has already become glucose intolerant, impaired
Now,
glucose tolerance.
my question is, does all this can be explained by the medullary cancer?
Yeah, so that's the thing. That's the interesting bit. That's why this is very interesting. Medullary carcinoma of thyroid rarely able to produce ectopic ACTH
Mm.
because of genetic mutation.
Right.
So his ACTH is not coming from pituitary.
Ah,
It's coming from the medullary carcinoma of thyroid. So this is an ectopic ACTH syndrome.
wow.
There's a severe ectopic acidosis syndrome with severe hypercortisolemia causing cardiometabolic effect on him.
And how to prove this is ectopic?
So, for the context, this is quite obvious, number one. Number two, to prove that this is not coming from pituitary, I mean, for your intellectual satisfaction, you can do bilateral inferior petrosal sinus sampling,
Right.
or you can do a CRH test
Mm.
where you inject corticotrophin releasing hormone
Yeah,
and see if corticotroph goes even higher. If
yeah,
it does, that means it's pituitary. If it does not, if
right.
the response is blunt, it means it ectopic.
But you didn't need those in this scenario because you have
For the
explanation.
context, you don't
You don't
need
need.
this. This is quite obvious. I
Yeah,
mean,
yeah.
it would be it will not alter the management very much. Now he of course need treatment
Hmm.
by the endocrine oncologist from or endocrine oncology MDT for
Yeah,
medullary thyroid. He needs screening for MEN2A. That's all fine, but
right.
this is urgent.
Yeah, yeah.
The so severe hypercortisolemia.
Exactly. Very, it sounds like very urgent because from
Yeah.
600 to 1400 is very
And what
rapid.
it does,
Mhm.
it causes this high cortisol, of course, cardiometabolic complication. He
Yeah.
started having it.
Hmm.
Second, immune suppression. He's
Immunosuppression.
very immune suppressed, and he would catch a catastrophic sepsis at any point, and
Yeah, yeah.
he would fall dead. Third, he would then be at risk of catastrophic clot
Clot.
because this is very prothrombotic state.
It is with AF.
of course, one with AF, two with hypercortisolemia.
Hyper.
Hypercortisolemia is a prothrombotic state.
Hmm.
So catastrophic, you know,
Consequences. I mean,
catastrophic clotting,
it sounds like he can
massive
collapse.
PE.
He can
Yeah,
collapse in any minute like this, you know.
yeah,
And with this cardiometabolic immunosuppression, it could be severe sepsis
yeah,
or thrombosis somewhere, you know.
exactly.
Um,
Thrombosis, yeah.
wow.
Yeah, thrombosis, I think, is most scary. He's an anticoagulant, which is fine. It will keep
Mhm.
him safe.
Yeah,
But even though,
yeah.
no, okay, he's getting. I'm describing the case for too long now. I will raise two questions and then over to you. One, do you think at this point s- something else could have been done in ED
Mm,
at the very beginning?
mm. That's a very good question. Again, it is again the ED presentation can be very brief,
Yeah.
you know what I mean, and very focused, and he may not have a lot of symptoms late, which
Mm,
he developed later. But I think the first presentation is
mhm.
going to be challenging even for anyone to think that level of
Yeah.
thing. Um, but if he comes on,
Hypokalemia.
if
Yeah. Sorry.
if he comes to ED now after cortisol
Yeah.
high, low potassium, AF, DEXA, um, quite men syndrome. My goodness. So all these again at our view we might involve medics critical care maybe depend
Yeah.
you know so we need to do something aggressive to
Hmm.
stop this cortisol. I don't know how, again, from ED point of view. So, and also my question would be the men screening is still ongoing in the background, isn't it?
Oh yes. This is rather, I mean, less
Yeah.
urgent part now to screen out
and
more cancer.
and my
It
my
should be
thought.
done, and this is being done. But now the priority is planning treatment for
Yeah.
what we already have, and also keeping him safe from all the consequences of hypercortisolemia.
Yeah, my thought is from again, I would ask, I would involve if the patient is in ED, I would involve the endocrinologist like you yourself, asking, so how can we stop the cortisol? How can we how can we
Yes, excellent
stop the
question.
cortisol? I would call you,
Yeah,
hello endocrinologist, I'm in ED, I have no idea how to manage this patient. Can you come and help us?
yeah. I mean, even now, how to manage this hypercortisolemia is an interesting question. Of course, this will be an MDT
Mm,
decision. The key person in the MDT would be oncologist.
yeah.
It should be ideally thyroid cancer MDT.
Uh-huh.
Um, this can also be neuroendocrine tumor MDT,
Hmm.
getting involved in planning and management. However, the challenge is now
Hmm.
because if you treat this medullary carcinoma of thyroid,
Right.
and it will take time to reach a remission, you need to do something to treat that cortisol more urgently.
Yeah. I think my understanding is yes, there is a medullary cancer, but what's killing the patient now? Okay.
Yeah.
I
Well,
would be worried about this high cortisol affecting the cardiometabolic, part, hypokalemia, and edema and
yeah.
all these things. So I think my feeling as a emergency physician, I would be thinking, well, we know there's a cancer, there will be MGT, take the plan forward for the cancer point of view. But what's the immediate treatment?
And that need to be done like urgently.
Yeah,
All the cancer treatment need to be done very, very urgently.
yeah.
However, at the same time, this cortisol need to be treated. And how do you do that? We have to do something so that the adrenal doesn't
Mm,
respond to that high ectopic ACTH. Do you know what I mean?
Exactly. So there is ACTH, you're saying ectopic ACTH. So the
Yes.
question is, like a lay person, I'm asking you this
Yes.
question. So is there any way to stop the either one thing is we can is there any way we can stop the ectopic ACTH, or is there any way we can stop the adrenal to respond to that ACTH?
Yeah, there's ways for both. Number one, you are treating the cancer, which will stop ACTH production, wouldn't it?
Yeah,
But I'm trying to say that might take
take a while.
long
Yeah,
time.
long time.
And by that time, cortisol will burn him out
True.
in the multi-system level. So, which is why, while we plan and manage the cancer and hope that ACTH will come down, meanwhile, we should treat hypercortisolemia itself by neutralizing the adrenals, and you can cause it. You can do it medically. There's
Mhm.
a drug called
What is it? Metarapol.
metarapon, or
Metarapon. Yeah.
ketoconazole, which
Right.
is an antifungal.
Mm-hmm.
They inhibit enzymes in steroid biosynthetic pathway in adrenals, and they can stop cortisol production very significantly. So this patient actually need to be under an endocrine, well, of course, jointly under endocrine and oncology team, but under an endocrine team as an inpatient, ideally to 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 be treated with meteropon or ketoconazole
Wow.
with very meticulous monitoring of of response by observing cortisol level and other metabolic and biochemical parameters.
And that works very quickly. This
That works within days.
within days. Mhm.
Within days, yeah.
Wow. So you're talking about now a medical adrenalectomy.
Yes, yes. I mean, more urgently,
Yeah, yeah.
while at the same time prioritizing the cancer treatment as well.
Interesting. Very interesting.
Yeah.
That is really, really interesting because there is first of all, there was a dilemma of the diagnosis, starting from the lungs and then
Mhm.
thyroid and then the genetic confirmation. The other part of the challenge is treating the source of the problem, which is the medullary cancer
Yeah.
and the acute symptoms.
Yeah.
So, isn't it?
Yeah,
And
of
then
course. I mean, hypokalemia need to be treated.
exactly.
If it goes severe, that needs a bit of cardiac monitoring. Um, Patient need to be protected from any catastrophic sepsis. We also need to think about that cerebral mets. Where is it going?
Yeah.
So there's a lot of thing, and his with all these things, mental health support and psychotherapy is also important.
Wow.
So that's another dimension. Imagine someone fitting well, completely
Wow.
moving on with his life.
And you said it was
Six
last
months ago.
October. So he presented in October. Now
Yeah, from
it's
October to
February.
January. Yeah, it's catastrophic.
Is he still under investigation, or is he done any treatment so far?
Mm, uh, he's awaiting for the first treatment under thyroid cancer MDT.
Okay. And the ketoconazole started yet, or just
No,
waiting
no,
for the MDT?
no. It's all very recent, Farooq bhai, if you
Very recent.
see
Okay.
the
Yeah.
timeline. Of course,
I
I
mean,
can't disclose much of
no.
identifiable data, but
But I'll be interested to know what happened next in
yeah,
this particular case
we can discuss the outcome
as an outcome. But
later.
yeah, but
Yeah.
I would say this is amazing. Even if I'm in a medical background, or if I were in the medical team, or even as an endocrinologist or respiratory consultant, I think it's a bit of challenging for everyone to to
Of
to
course.
get all the puzzles together, um, think of purely what sort of title line, and as a
Mm.
patient it's a devastating for the patient as well. Hmm.
True, true, of course.
Right. So it's a very interesting, and for the audience, I think we got. I think this is one of the very interesting case for anyone, which is, I would say, chest pain endocrine case. Interesting chest pain, and to be honest, in emergency department, we almost never think of endocrine cause of chest pain. Okay,
There's not much, to be
not
honest.
much to be honest. Okay, and of course, unless there's some symptoms, we don't even do chest X-ray for chest pain. Yes, in this case, we did ED. In ED, they did troponin, ECG, and I'm surprised they involved AMU, like acute medical unit doctors, and
Mhm.
they refer to cardiology. That also not always happens that quickly. Usually, they go back to GP, and GP organize the cardiology follow up. So in a way, I would say it was done fairly quickly for this gentleman,
Mhm. No,
right?
I think so. Things moved quite,
Very fairly
quite
quickly. It
rapidly.
wasn't like a near miss or anything. And he also evolved. His symptoms evolved throughout the time. And by the time endocrine got involved, I think it's fairly obvious that it's medullary carcinoma. And then we're discussing about which way to treat and
Yeah.
how. Um, Thank you, Dr. Said. It's I would say we learned a lot from this case, and would be keen to uh, next we would be keen to hear the outcome of the case when it happens after the next MDT. Is
Yeah.
there is there anything for the audience you'd like to mention? How also my output question is if how what we could have done differently in ED.
Oh, interesting. Of course, the chest X-ray could have been done on
I
first
agree.
floor. That
Hmm.
was an obvious one. Um, Hypokalemia could have been investigated in otherwise fit and normal person who's
Did he
presenting
had
with
in ED?
hypokalemia.
Did he had hypokalemia in ED? First
I
presentation.
I don't remember him having hypokalemic episode in ED, but he definitely had it when he was admitted under medics.
Hmm.
He
So,
had it recurrently, so that could have been investigated
hmm,
more robustly with 9 a.m. cortisol and other
nine. Okay. Hmm.
other risk factors. Um, fluid retention, fluid retention. They should have an answer
Hmm.
for fluid retention. Why somebody is so young and fit and
With a
well,
normal echo,
so with a
yeah.
normal echo having fluid
Why
retention.
is he retaining fluid? Hmm.
Yeah, with normal liver function, normal protein, normal albumin.
Yeah.
Why somebody started retaining fluid all on a sudden?
Very, very.
If they were looking for causes for generalized fluid retention with recurrent hypokalemia, they
Yeah.
would find something.
Exactly. Hmm.
Mhm.
Very, very interesting.
Yeah.
Uh, was that patient had multiple admissions, or after the initial presentation, was he
I
had
think I think I think he had two admissions all by
under
now.
medical team? Okay.
Yeah.
Yeah, I think you're right. Maybe during that period, somebody could have early had a query of edema and hypokalemia and do some background. Might have that could have been done, to be honest. Yeah.
Yeah.
Thank you.
Otherwise, I think it was very, very good workup, very good diagnostic workup. It
It
went
is.
well.
It is.
Mhm.
All right. So thanks again, Dr. Said. You
You're very welcome for a
given us a challenging case that I would say that could have gone to a TV series like Dr. House. These cases, if you
Yeah.
haven't seen Dr. House, I would recommend you to watch in Netflix tonight.
I will then. I don't watch telly much, but I will.
Yeah. But thanks again. We will catch up with you again next session. Thank you so much.
You're very welcome. Thank
Bye.
you.